So we're going to go ahead and move on to session 2. And John?
Yeah, so as you can see, we're moving down the GI tract as we're moving to the small intestine and the colon now. And in terms of the disorders of small bowel, this is going to be presented by Lucinda Harris, who is once again an expert in this particular field. Currently, she's at Mayo Scottsdale and is definitely a leader in small bowel diseases. And then we're going to shift once again, moving down to the colon, disorders of colon rectum, and that's going to be presented by Dr. Moshiree. She's at the Division of Gastroenterology at Atrium Health in Charlotte, North Carolina. And once again, another world authority on disorders of the colon, anal rectal junction, and the bowel.
Fantastic. And so we'll hope you enjoy it.
Hello, my name is Dr. Lucinda Harris, and I have been asked to talk to you today about motility disorders of the small bowel. I would like to thank the IFFGD for the opportunity to do this talk for you and tell you a little bit more about motility disorders of the small bowel. So what is the small intestine? Well, it's kind of a misnomer to call it small because it's really not so small. It's about 20 feet long. And this is the small intestine right here. It's called a small intestine because of its cross-sectional area. And it consists of 3 areas, the duodenum, the jejunum, and the ileum. And I'm calling it the middle child because it's located between the stomach and the large intestine. One of the things to be aware of from a functional point of view or mechanical point of view is that if there are problems in the stomach or in the colon, the small bowel may be affected as well. It's also the place where digestion and absorption of your food take place. So it moves and absorbs. That's its kind of primary thing. And it's composed of the enteric nervous system. There are over 600 million neurons that are located in both the lining and the smooth muscle of the GI tract. It's been called the second brain because it can operate independently of both the central and peripheral nervous system. And as I said before, what it does is digest and mix the food and absorb nutrients. How it does that is by various cells that are located in the lining of the small intestine, and it depends on something called peristalsis. And peristalsis means that there are waves of coordinated contractions and relaxation that move the food through the GI tract. There's also a little pacemaker within the lining of the small intestine called the migrating motor complex. And it's very important because it helps sweep the food and nutrients through the gut. There's also other wiring. So you think of the enteric nervous system as the nervous system that innervates or works in the lining of the small intestine, but there's a control system, often called the autonomic nervous system, that consists of sympathetic input from the vagus nerve and parasympathetic nerves, which are the splenic nerves. So what is a small bowel motility disorder? What do they mean when we say that? Well, it can be a problem with muscles and or nerves that control the movement in the small bowel. On the right-hand side of the slide, you can see a picture of the inside of the small intestine. The whole group of disorders is often called chronic intestinal pseudo-obstruction. And by that, it's meant that the intestine behaves as if there is a blockage, but there actually is no blockage in the intestine. And there are primary and secondary causes of this disorder. So primary chronic intestinal pseudo-obstruction is the type of pseudo-obstruction that occurs mostly because of genetic disorders. So there are familial visceral neuropathies, familial visceral myopathies, and types that occur sporadically. And there's also something called a mesenchymopathy, where there are defects in pacemaker cells called interstitial cells of Cajal. So these are primarily the genetic disorders, and they can occur in families, and they can have different types of transmission. Now, they are extremely rare, and they estimate that only 100 cases per year occur. There are also secondary causes of pseudo-obstruction, and these make up about 60% of the small bowel dysmotility disorders. These can occur because of infection, like viral infections. Chagas disease is a disease that occurs in South America due to a parasite known as Trypanosoma cruzi. There can also, and probably this is the most common type of pseudo-obstruction, occurs because of connective tissue disorders like lupus and scleroderma. There are also autoimmune causes that occur because of diseases like myasthenia gravis. They can have endocrine causes. Another not uncommon cause is cancer. There can be what they call paraneoplastic syndromes. That means syndromes that are associated with someone having cancer that slows down the motility. There also can be pseudo-obstruction due to drugs, and the most common medication that causes that is usually the narcotic medications that people take for pain syndromes, but also some of the medicines that people use for Parkinson's disease, the L-DOPA medications can cause that. And there can be miscellaneous causes. Another fairly common cause of pseudo-obstruction can be radiation and even Ehlers-Danlos, which is a defect in the connective tissue, which can take many forms and has been coming to more popular discussion lately, can cause pseudo-obstruction. Well, what are the symptoms? That depends a lot on the part of the GI tract that's most effective. It's important to know that men and women are probably fairly equally affected. The disorder can be sort of like chronic low-grade symptoms of nausea and abdominal discomfort, but oftentimes people may have what we call acute attacks. And these acute attacks consist of nausea, vomiting, severe abdominal pain that can be very sharp in nature. It is often also associated with bloating, and constipation is very common. Patients also will complain of feeling full fast, that's called early satiety, loss of appetite, and there often is weight loss. One of the complications that is very common in small bowel disorders is that patients can get what's called bacterial overgrowth, and that can cause diarrhea. So usually the small bowel doesn't have a lot of bacteria in it, but because the intestinal motility is not working to sweep out the bacteria, patients get diarrhea. And bacterial overgrowth is covered in other educational videos. So I will refer you to that because that would be a whole lecture within itself. Other common symptoms are difficulty swallowing, heartburn, chest pain, and the disorder can affect the urinary symptoms of the urinary tract. So patients have symptoms emptying their bladder or getting urine started. How do we diagnose chronic intestinal pseudo-obstruction? There can be blood tests that look for inflammation and autoimmune markers. I've already shown you plain X-ray, but we can also use barium and CT scans and MRIs. Endoscopy can help us rule out that there's no mechanical obstruction. There's a test called manometry, which is a flexible tube that's inserted in the GI tract, either into the esophagus or the rectum, that can take pressure measurements that can suggest this disorder. We also, and you see it pictured here, have wireless motility capsules that people swallow, and we can tell and track this capsule and look at how fast the gut is moving. We can also do that with another X-ray modality called nuclear medicine studies, where we have patients eat a meal that's nuclear tagged, and we can tag how long it takes for food to go through the GI tract. We also use breath testing for diagnosing the small intestinal bacterial overgrowth. There's another modality called radio-opaque marker studies, which are little markers that people swallow, and we take serial X-rays to tell how quickly those markers are moving through the GI tract. Very rarely, we also can do full thickness small bowel biopsies that can look at the cells and see where the defects are more completely. To manage chronic intestinal pseudo-obstruction is to really do supportive care. So most of the symptoms result in problems with nutrition, and so certain diets are recommended. There can also be drugs used, and the drugs that we most commonly use are called prokinetics. And we use antibiotics to treat bacterial overgrowth. We can use pain management, but we try to avoid narcotics because of the fact that they slow down the gut. If there's a cancer, we treat the underlying cause. We also have to pay attention to lifestyle. There can be complementary medications and visceral massage that helps. And in very small number of cases, we can use intestinal transplant. In the next two slides, I cover some of the medications that are commonly used to treat intestinal motility. They oftentimes are not indicated as medications specifically for the disorder. For instance, prucalopride is actually improved to treat chronic constipation. There are really no medicines that are approved by the Food and Drug Administration to treat this disorder. We also use medications called anticholinesterase medications, primarily pyridostigmine, which you can titrate up in small amounts. And you can see that a lot of the medications have a lot of side effects. For instance, pyridostigmine, because it works on muscle receptors, can cause diarrhea and also muscle twitching. Just a moment to discuss small intestinal bacterial overgrowth. The small bowel in good health only contains a small amount of bacteria. There can be a variety of antibiotics that are used. The important point here is that probiotics are not helpful, but promotility agents may help to sweep some of the bacteria out of the gut. So in summary, chronic intestinal pseudo-obstruction is a very rare disorder divided into primary and secondary types. The problem is either in the muscles or the nerves of the small intestine or both. It has both chronic and acute symptoms most often being nausea, vomiting, abdominal swelling and pain, and weight loss. The treatment is mostly supportive. And certainly, as my dog Danny demonstrates, food is very important to us. And it really is an impetus for us to seek more treatments, and research is desperately needed in this area, even though these disorders are rare. Thank you for your attention.
Hi, everyone. Today, I'm going to talk to you guys about disorders of the colon and rectum. And we're covering session 1, which is really pathophysiology and diagnostics. My name is Moshiree. I'm at Atrium Health, which is located in Charlotte, North Carolina, and I'm director of Motility here. So the common diseases of the colon will be covered first. These are diseases and syndromes, I would say. So diverticulosis, we will cover, pretty in depth, since this is actually pretty common. Irritable bowel syndrome is also a common disease syndrome that is special to me because it's an area that I do research in. And then inflammatory bowel diseases are ulcerative colitis, Crohn's disease. We'll also cover constipation, but not diarrhea syndromes, as this talk is only 20 minutes. Colonic ischemia, infectious colitis, sigmoid, and cecal volvulus can also develop, and then polyps and tumors. So diverticulosis, this is very common. You know, it's often asymptomatic. So patients who have this condition don't have any symptoms. And this, you can see on the colonoscopy photos here, where there's these outpouchings in the colon. And what is the cause of this is it develops from what we think is herniation of the colon mucosa and what's beyond the colon mucosa, which is called the submucosa, and defects in a muscle layer in the colon that's within the wall. And this occurs at sites that are penetrating blood vessels in the colon. And again, it's extremely common, and it's usually found just incidentally when we're scoping a patient. And scoping a patient means doing a colonoscopy. And these patients can have, other than just having no symptoms, they can have diarrhea, they can have constipation, bleeding can occur. When bleeding occur, we call it diverticular bleed. And they have just red blood for rectum. Sometimes it's like dark blood. And if there is pain in patients who have diverticulosis, it's from either spasms or this underlying inflammation that can occur. And then when the diverticula become infected, we call this diverticulitis. And how it's diagnosed is by a CAT scan that shows there's inflammation in the colon. And most of the time, those patients get placed on antibiotics. There are risk factors for diverticulosis. Those are the risk factors are being on a low fiber diet. So, you know, in the United States, Australia, westernized societies with low fiber intake, there's a higher risk. Age is a risk factor. You know, 50% of patients over age 70 will have some kind of diverticulosis. And then obesity, use of non-steroidal medicines like, you know, the over-the-counter formulas like ibuprofen, Advil, all of those can cause it. And then drugs like opiates, which is Crohn's disease. There is some diagnostic testing that's, you know, recommended in patients who have suspected irritable bowel syndrome. And these are really recommended in patients who have more of the IBS with diarrhea. And the most important is to test patients who have irritable bowel syndrome and the diarrhea kind for celiac disease, and that can be done by blood tests. And these are the blood tests that are listed here, are IgA tissue transglutaminase and quantitative IgA. We also want patients who have the diarrhea kind of irritable bowel syndrome to have testing with stool tests, specifically for fecal calprotectin and lactoferrin for inflammatory bowel diseases at least once. If they're having a colonoscopy, because they also have other alarm features, such as they're over, you know, we say now actually 45 years of age, you know, blood in the stools, symptoms at night, you know, unintentional weight loss, changes in symptoms, antibiotic use, and a family history of organ disease or organic GI disease, such as inflammatory bowel disease or celiac, that if they're having a colonoscopy, they should have biopsies of the colon so that we make sure that there's not this other thing called microscopic colitis, which is found in, you know, 1.5% of patients who have irritable bowel syndrome. The differential diagnosis for constipation, it's very wide. So what can cause constipation could be medications. For example, NSAIDs, again, things such as ibuprofen, aspirin, Advil, pancreatic enzymes that patients are on for chronic pancreatitis, possibly, although that's a little bit controversial, opiates or narcotics can cause constipation. Some of the antacids, like Tums, can cause constipation. Even some PPIs can cause constipation. These are frequent drugs that our patients take. Bile acid sequestrants can be constipating, and then drugs such as anticholinergic drugs can constipate. Now, other than drugs, irritable bowel syndrome with constipation makes up 20% of the constipation population. 40% of patients who have pelvic floor dysfunction, you know, are diagnosed as having chronic idiopathic constipation. So we'll talk about that, what that means even. And then 2% of the patients who have constipation have something called slow transit constipation, which is an impairment in how the colon is able to contract and move forward. And we can do diagnostic tests for that. And then there's chronic idiopathic constipation, which the US prevalence is like 12 to 19%. So these are high. The diagnostic evaluation is a rectal exam. So the best way that we have as physicians and caretakers and APPs is to do a rectal exam. So the importance of the rectal exam is that it's, first of all, visual. So we look to make sure there's no what's called rectal fissure. We make sure there's no hemorrhoids, which can result from severe constipation and straining. We make sure there's no rectal prolapse, which is a protrusion of the rectum that comes through the rectum as a result of people straining so much to have a bowel movement. And then we can obviously palpate for a mass in the rectum, make sure if we feel hemorrhoids inside, that we're treating patients for that. And then testing the muscles and seeing if the patient, when we ask them to do squeezes and push out our finger, are able to coordinate the correct muscles to be able to do that. If we feel really hard cemented stool in the rectum, then that can lead to other diagnostic testing that the patient may need. So the most important diagnostic test is our finger, especially for patients who have constipation predominant IBS. And then I would say also for the mixed type IBS patients, but really every patient should get that at least the first time. Now, for severe constipation, that's the 2% of patients who try the relaxative, whether it's over the counter or not, nothing's helping. Colonoscopy is actually just only indicated if you're 45 and up for colon cancer screening. So colonoscopy is not a test that's necessary for constipation, unless the patient has iron deficiency and other stuff going on. Now, there are transit studies that can be done. Those are called whole gut scintigraphy, which is only available in a few centers such as Mayo Clinic. There's SITS marker study. That's a radio-opaque marker study depicted here on an X-ray. Then there's wireless motility capsule, which involves a capsule the patient swallows, and it goes through the entire gut. And we look at both the gastric, the small bowel, and the colon motility to see if we can see good contractions or not throughout. That could be one of the causes of constipation. And then there's manometry, where we actually put a probe inside the rectum and we measure pressures in the rectum. We ask the patient to do certain maneuvers. We ask them to strain. We ask them to squeeze. We ask them to rest during the test. And we check the nerves and muscles and how they're functioning in the rectum. There's also another test called the balloon explosion testing. Then we have MRI defecography, where contrast is placed into the rectum, and we can see if there's what's called a rectal seal, which is an outpouching of the rectum that occurs. You can see it here on evacuation, depicted at the arrow, where there's an outpouching that occurs anteriorly towards the vagina. This back here is the spine. And then we really can look at the anatomy of the rectum and see how is the rectum coming down in the pelvic floor. Is it able to allow the patient to defecate? Then there's acute syndromes in the colon. So these are colonic, what's called pseudo-obstruction, which is an obstruction, but it looks like it. Obstruction would be a complete narrowing of the colon wall, and that ends in surgery. And then ileus is where the colon just doesn't move. It's almost like a paralyzed colon. It won't move. Usually results because the contents of the small intestine are not able to contract and move forward, or it can occur in the colon. And this is usually due to inflammation from some systemic illness or something else going on. It could happen post-op. And there's an extreme pain that occurs with this. So patients usually have extreme abdominal pain. It comes on suddenly. The abdomen is just very distended, tight. Patient may vomit, and then hopefully it resolves completely. The most common cause of an ileus is either abdominal or retroperitoneal surgery. And this is a common cause of like hospitalizations, and what revs up the cost of hospitalizations in the country. It usually resolves in 48 to 72 hours. It's really important for any surgeon that operates on the colon or the abdomen to put patients on a drug that can prevent the effects of an ileus, and those drugs do exist. And also to really limit opiates after surgery, because opiates themselves paralyze the colon and the small bowel and the stomach. So giving too much of them can be problematic. This is Ogilvy. There's actually a syndrome that's named after the surgeon who was actually a war veteran in the Balkans and served in World War I and World War II. And this orthopedic surgeon, also the GI, he was a sailor as well. And he defined this acute massive colon extension that can occur in some patients. Usually they're institutionalized or in nursing homes. And, there's a complete extension of especially the right side of the colon, and there's no mechanical cause to this. And usually this is self-limited and hopefully will recover. Otherwise, there is a mortality associated. So the signs are distension. It occurs over 3 to 7 days, very acute, can occur over 24 hours. 80% have, mild to constant pain. There is significant distension usually, some painless. 60% have nausea, vomiting, 50% have symptoms of constipation, and most patients will have good bowel sounds when we listen. But it can also be due to excess dehydration or when the electrolytes like magnesium, phosphorus, potassium in a patient are abnormal. This is what it looks like. So on X-ray, it is this black area is just distension of the colon. It can dilate to like 20 centimeters sometimes. This has a risk of perforation, which is the colon can just pop. And as a result, patients can develop sepsis, and usually patients get really sick. X-ray and CAT scan is the way to diagnose this. And usually the CT scan is better than all the other imaging. This here is a picture, it's a sigmoid and colon volvulus. So you have a sigmoid volvulus over here on the left side, and the colon just is so distended, it's like a balloon, it pops like with air. And then here you have a cecal volvulus where it looks like a little kidney bean out here, where the right side of the colon is just completely distended. It's compressing on the left side of the colon, which is over here. And as a result, these patients are also at risk of having a perforation. And with the sigmoid volvulus, we do a colonoscopy to decompress. With the cecal volvulus, which also develops acutely, these patients usually have to go to surgery to get that part of the colon resolved and removed and untwisted. So just to show another picture, there's actually a disorder called, Chagas disease, which affects the esophagus. There's one called Hirschsprung disease, which affects the rectum, where the rectum muscles do not relax. And as a result, patients develop what's called megacolon. And these conditions are all due to these pacemaker cells being lost and deficient. And things that can attack the pacemaker cells in the gut are things like viruses, for example, COVID-19, other infections can affect the pacemaker cells. And these pacemaker cells go from esophagus all the way down to the colon, and they are located in where the nerves in the gut are. So they're located in what's called the mesenteric plexus and the submucosal plexes, and they're also within the muscle layers. And so this is what promotes movement of the gut and helps motility of the gut. So I thought it'd be good for you guys to see the picture of that. And if those don't work, then you get these other conditions that we're talking about here. So this is a SITS marker study where we ask patients to, again, swallow a capsule, and then it breaks up into 24 pieces, and we count how many of these are left after 5 days of ingestion. And we look for these clearance to see if there's a portion of the gut in the colon that's not working. And if they're abnormal, it could be that there's slow transit constipation or the pelvic floor is not allowing relaxation. So when we diagnose patients with dyssynergic defecation, we use this 50 ml watermelon balloon, and it's depicted here. And that goes in, it has polyethylene catheter that's attached. We go past the puborectalis muscle that goes around like the sling around the rectum that allows us to have continence so we don't poop on ourselves. And then we see if the patient is able to expel this 50 cc balloon in the 2 minutes they're given. The patient sits on a commode, and that's one way that we can test and see if the patient has dyssynergic defecation. Now, this has to be complementary with another test. So usually for the other test, we use what's called the anorectal manometry. And that test is done in dedicated motility centers and done by some colorectal surgeons around the country who operate on the colon. And this test also helps us determine if the patient has this problem. So here we have the picture of the coccyx bone and the back. And the rectum is depicted here with this angle. And so normal physiology, when the patient is straining to have a bowel movement, what should happen is that that angle needs to straighten up more during that straining. And as the angle of the rectum straightens, the puborectalis muscle relaxes, and that allows stool to pass. So when we don't want normally patients to push so hard, because if they push and strain a lot, they get hemorrhoids, they can get fissures, and they may not actually be able to coordinate the muscles correctly to be able to push it out. Hemorrhoids are pretty common. 40% can cause bleeding. There's a lot of swelling that's involved. Some of them itch. It's in 24%. And then pain does not occur in hemorrhoids unless they are what's called thrombosed, which means the blood supply to the hemorrhoid is cut off. So those are the painful ones. And if a patient has pain, that should prompt evaluation for some other cause that's coexisting with their hemorrhoids. So again, 50% of patients have hemorrhoids by the time they're 50. 10 to 20 million people have active symptoms, and then 5 million patients seek, attention every year for this. We spend a lot of money on over-the-counter medications, and most of the colonoscopies, that we do on an inpatient setting, are done due to bleeding from diverticulosis and hemorrhoids. So these are really common. And then most are just treated with relief formulations that are over the counter, and then steroids. So this is the anatomy of the hemorrhoids. You can see the internal ones are inside and past the dentate line, and then you have the external ones that are more outside, and if they get thrombosed, they're extremely painful. The risk factors for hemorrhoids, so lack of fiber and fluid intake has been a potential risk factor. Sitting too long on anything, even at a desk, like we've been doing during COVID, virtual interviews and everything, can be a cause. Sitting too much on the toilet, straining too hard, ignoring the urge to defecate can be all problems. Patients who have connective tissue diseases like scleroderma, lupus, Ehlers-Danlos have increased risk of hemorrhoids. And then any condition that increases the rectal tone can also cause it, anxiety, etc. So it's usually due to the enlargement happens because of the weakened muscle and the elevated sphincter, which is the muscle in the rectum tone, and then an increase in abdominal pressure. We diagnose hemorrhoids by visually inspecting them. We also, of course, the rectal exam can be helpful because you can palpate it. Anoscopy is the way that we can look at the anus area, and usually it's done by a GI doctor or surgeon. And then flexible sigmoidoscopy is where we use a colonoscope and we go up the rectum and the colon, and we're able to see in backwards view of the rectum and in forward view whether a patient has a hemorrhoid. So in any patient that has a hemorrhoid, we also have to consider what if they have this pelvic floor dyssynergia, which is, again, so common in patients with constipation. They could have what's called the anal spasm that's causing a fissure. We'll talk about proctalgia fugax and what that is. And then, of course, an abscess in the rectum, which is an infection around the rectal area, can cause problems, and especially that's seen in patients who have Crohn's disease. So anal fissures, it's almost like a paper cut of the rectum. The rectum has a lot of nerve supply, and it can be extremely painful to have these rectal fissures. So these are patients that have either acute or chronic pain. 90% of them are located posteriorly, so towards the spine. Any trauma, like a hard stool, sexual practices can cause fissures. Inflammatory bowel disease patients, especially Crohn's patients, have a higher risk. We have to make sure there's not cancer infiltrating, but most of them are not related to any cancer. They can happen post-op, and then infection is it. Moving on to fecal incontinence. So this is fecal leakage. There are structural reasons why patients would have fecal incontinence. There's stool characteristics that may be a reason, such as even having hard stools, and then functional abnormalities that can cause it. Fecal incontinence is highly prevalent. It's seen in 9% of the population, and it's actually common both in men and women. In women, it's 9%, and in men, it's actually 7%. And in people who are over 70 years of age, it's 17% is the prevalence. So it is very, very high. We do have diagnostic testing for fecal incontinence. That's done with, again, an anal rectal manometry to see if the sphincter pressures, the nerves are okay. There's ultrasound that can show if there's a defect in the rectum. For example, a woman who had a vaginal pregnancy maybe 30 years ago and had an episiotomy would be at risk. And then there's testing that we can do with EMG, which is done to distinguish whether there's a nerve or muscle problem, and those kind of have fair evidence behind them. So the summary of all diagnostic testing we have, there's functional assessments with the anal rectal manometry that's done with this probe and catheter. There's ultrasound to see if the sphincter muscles are intact. There's defecography. This is fairly new, but it's kind of a nice way of evaluating. The MRI is new. There's also barium defecography to see if there is an evacuation disorder, if there's a structural problem, for example. Sometimes the bladder is falling down and is putting pressure on the rectum, and that's the cause of patient symptoms. There's EMG, which is done when patients go through physical therapy, which is very effective for a lot of these pelvic floor disorders. Then there's pudendal nerve motor latency, which we didn't talk about, which is a way to assess the sacral nerve function, especially in diabetics. And then there's new stuff like this little depiction here that looks like a wine glass that's flip, but for the rectum, where we actually evaluate if the rectum is able to distend adequately. Some patients have poor compliance and the rectum is not able to distend appropriately. So then there's polyps, right? So of course, this is not a talk on colon cancer screening, but it's really important to get some kind of colon cancer screening, whether it's a colonoscopy, virtual CT colonoscopy, fecal DNA testing. It's important in patients who are age 45 and up, and those who have risk factors or family history of colon cancer. April was Colon Cancer Awareness Month, just like it was IBS Awareness Month, and it is really important to be cognizant of getting screening tests done. So polyps can develop into cancer, and colonoscopies save lives. Now, for the functional rectal pain syndromes, this is Proctalgia fugax and Levator Ani syndrome that we'll talk about. Levator Ani syndrome happens more in women. They're usually younger women. It's a rectal pain that's intense. It's can happen intermittently for 2 weeks, and it can last over 20 minutes at times. It's vague, dull type of pain. It doesn't awaken the patient at night most of the time, and it worsens when the patient is sitting or defecating. And usually walking and lying down helps it. So this muscle that's in the rectum kind of spasms, and that can be very painful. Then there's something called Proctalgia fugax that happens in young men, really type A personalities, high performing folks can have this. It's a sharp stab-like pain. So this is very painful as opposed to like an ache that happens with Levator Ani. Wakes up the patient. It's usually induced by stress, where the patient just kind of tightens their sphincter all the time. And it's a smooth muscle dysfunction, and patients who have IBS can also have it. Anorectal manometry, which is depicted here, is the way we diagnose it. So we test patients' squeeze, we test their muscle control, we test their relaxation, and all of that in a color topography as we depict here helps us determine whether patients have these conditions that we talked about. So lastly, happy birthday, 30th birthday to IFFGD. You're 16 years younger than me. So, still in your youth, and I'm sure you'll have fantastic accomplishments as the years will roll on. And I'm excited to be working with you guys on several projects that this great team of ladies and gentlemen, but a lot of ladies have really formed. So it's great to have you guys really advocate for our patients. Thank you so much.
Hello and welcome back. I hope you enjoyed those two presentations from Dr. Harris and Dr. Moshiree on the small bowel or the small intestine and the colon. So first with Dr. Harris's talk, she, is, an expert in the small bowel. And I know that one of the things that we hear a lot about here at IFFGD is questions about that relate to food. And one of the big things that we hear is about gluten and gluten sensitivity versus celiac, and why that's important, and why are doctors always looking for that. Can you talk a little bit about that issue with gluten?
Sure, I think I can take this one.
Okay.
Celiac disease and gluten sensitivity, there's a lot of overlap and discussion about this, and people get confused, but celiac is actually a specific disease that is diagnosed with abnormal test results that suggest that there might be this autoimmune process that's destroying the ability of the small intestine to absorb stuff. Gluten sensitivity is really kind of more of a reaction to the gluten, and it's a little bit harder to define because there's not a distinct blood test for that. In fact, many people who have gluten sensitivity get those symptoms, but their testing comes back negative, their biopsies come back negative, that don't show any abnormalities. So that's where the distinction is. But I think, in terms of gastroenterologists, when people come in with all different types of complaints, whether it's diarrhea, bloating, abdominal pain, and many times we want to rule out celiac disease because it is pretty common. Depending on where you live in the world, it could be 1 in 100 people have celiac disease. And then if you layer in all the people who are kind of sensitive to gluten, then you're looking at a pretty high number of people. So it's really important to remember that when you come in with these complaints and vague symptoms, we look to celiac a lot to rule out, but there are people who are sensitive to gluten who don't have celiac disease, and those people tend to avoid gluten and they feel better. We don't know if it's that they're avoiding other things too when they avoid gluten that they feel better, but nonetheless, if they're feeling better, we don't really care. I think that's the most important thing when we're dealing with these patients. So it's an important topic. You're going to hear a lot about it when you think about gut health and gut, diseases in general.
Hey, Cecile, can I make one comment too?
Absolutely.
And what John mentions raises a really important point, and that is that this term non-celiac gluten sensitivity is probably a bit of a misnomer, because for celiac disease, where individuals have a disease that's genetically mediated and they're reacting to the protein in wheat, gluten, that's different than for patients that have non-celiac gluten sensitivity, where they could be reacting to, as John pointed out, any of a number of different things. There may be proteins that they're reacting to. More importantly, and oftentimes, they're reacting to a sugar in wheat called fructan. And so a better term for those patients than non-celiac gluten sensitivity is non-celiac wheat intolerance or wheat sensitivity. That's a more holistic term that is technically more accurate. And we should all be using that term and not using non-celiac gluten sensitivity.
Fantastic. And I know that some people, they will take themselves off the gluten and different wheats and then they feel better. And is there anything that they should be concerned about in doing that, making such an altercation in your diet long-term? Is there any risks of being on this diet long-term?
Short answer is no. A gluten-free diet now, there's such a wide range of foods that are available that are gluten-free that you can take a very healthy diet that's gluten-free now. Early on when we first started to do this, there were a lot of concerns about nutritional deficiencies related to a gluten-free diet. Those have largely gone away. So, people can live a gluten-free lifestyle and still be very, very healthful in 2021.
That is so fantastic to hear. Wonderful. So let's move on to Dr. Moshiree's talk. She made a comment when talking about diverticula again, which is a huge topic in the GI community. So when she was referring to diverticula, she said that sometimes they form due to a herniation in the colonic mucosa or submucosa. And so that seems very daunting to me. Can someone break that down a little bit easier?
Yeah, it is a little bit confusing. And, at the risk of getting too complicated, it's important to draw a distinction between true diverticuli, which involve all the layers of the visceral GI tract, so in the small intestine or stomach or colon. True diverticuli involve all the layers of the wall of that organ. But colon diverticuli, which are what are most common and what lead to diverticulitis, are actually pseudo-diverticuli. So they're not true diverticuli. They only involve the most superficial layers of the colon and not the whole wall of the colon. You might ask, well, how does that work? Well, remember that in the muscle that surrounds the colon, there are arteries that pierce through the muscle and go and provide blood flow to the more superficial layers of the colon. Where those arteries come through the wall of the muscle in the colon, if the pressure gets high enough, actually the superficial layers of the colon can herniate through those holes in the smooth muscle where the arteries come through. And by the way, this is also the reason why occasionally one of the more serious and dangerous complications of diverticulosis is rupture of those vessels that are coming through the same opening as that pseudo-diverticulum, and that can lead to massive arterial bleeding. So the take-home message for people in the audience is colon diverticula are not true diverticula. They're pseudo-diverticula coming through where those arteries come through the smooth muscle layer and only involve the most superficial layers of the colon.
And so involving arteries means people may find the blood in their stool.
That's right. That's right.
Because of that. Wow. So we do have a lot of patients that contact here at IFFGD about diverticulitis. And one of the common questions we get is about food and how do you eat if you have diverticulitis. And this is I understand
Yeah.
is a chronic condition, correct? I mean, it's something that you probably, if you were prone to have them, you will probably continue to have them. Is that
Yeah.
correct?
Well, yes and no. So diverticulitis is an acute event that will occur and either resolve on its own. And by the way, oftentimes it does resolve on its own without any treatment, or will require antibiotics.
Mhm.
But then things get better and patients usually do reasonably well for some period of time. They may very well have concurrent IBS, irritable bowel syndrome, that causes them to have abdominal pain and altered bowel habits, but that's not necessarily from the diverticulosis itself. So diverticulitis tends to cause acute intermittent symptoms. But you're right, there's a lot of confusion about diet, like what to do about your diet when you have a history of diverticulitis. In fact, for years and years and years, I think when John and I were
Yeah.
training, we were both taught, well, you need to avoid foods with seeds. You need to avoid nuts.
Right.
And it turns out that in large epidemiological studies done by a number of different investigators now, that's all false.
Yeah.
It turns out that those things are not contraindicated. You can eat seeds, you can eat nuts. They don't increase your risk of developing diverticulitis. John, I don't know if you have any other comments.
Yeah, no, I think it's really important to make that that statement so that people understand that, we tend to tell people what they can eat all the time, and that restricts people's behavior too much, and that affects your quality of life. And I think it's really important for us to debunk a lot of these kind of diets that get thrown out and this misinformation in many ways. And the other thing too that we should let the audience know, that just because you have diverticulosis doesn't mean that you're going to get bleeding or diverticulitis. It's rare, I mean, less than 10-20% of people will have something that's related to their diverticulosis. So if you hear that diagnosis, it just lets the doctor know that you have that. And if you do develop belly pain or bleeding, that potentially the diverticulosis for bleeding or the diverticulitis for the pain can be at play.
A good way to think about this, I always think about, like in your world, I always think about the analogy for a hiatal hernia, which is that there are a lot of people that have diverticulosis. There are a lot of people that have a hiatal hernia, but don't necessarily develop disease or symptoms as a consequence of those anatomical structural findings. So it's just important for people in the audience to realize that just because you have diverticulosis doesn't mean you're going to get diverticulitis or bleeding. Just because you have a hiatal hernia doesn't mean you're going to necessarily get severe acid reflux, Barrett's esophagus, or esophageal cancer.
Yep, exactly.
So are there any, so nuts and seeds are good to go, popcorn. Is there anything at all with diverticulitis that you would say, well, maybe talk to a dietitian about?
No, but here's the thing. Yes, but not in that sense. So what I would say is that one thing that people with diverticulitis should do is to consume a high fiber diet, because a high fiber diet will help to regulate one's bowel pattern. If you're constipated, it makes your stools a little bit more soft and makes you a little bit more regular. If you have loose stools, it tends to add a little bit more substance. And that's all good, because what we want to avoid is abrupt changes in pressure in the colon and straining. Okay, because straining tends to aggravate or make those diverticuli worse. So regulating the bowel habits, and the most natural, easiest way to do that is with fiber, is actually a pretty universal prescription for patients with diverticular disease.
Okay. Fantastic. Well, that was very educational, and I hope that you found that very helpful as well. I know it's a question we receive here a lot at IFFGD from social media, and also through our email address and our phone line. So just to bring a note to that for those of you who are watching today, IFFGD is here for you as patients, and please feel free to email us at any time, not just today with the program, but anytime that you have questions. We have an email address that you can email. It's iffgd@iffgd.org. You can also communicate with us via social media, direct message on chat, with Facebook, Twitter, or any of our social media channels. We do monitor those regularly, or there's a contact form on our website. So please do never hesitate to reach out and ask questions if you need help with your digestive illness.